order. First, Dr. Divya will be speaking on anatomic peculiarities in myopia. Part B, the domes, the dips, the cavitations, and the pits. Welcoming Madam on stage.
Okay, thank you very much, Dr. Anjana, for giving me this opportunity. So these topics given to me are all structural changes which are seen along with pathologic myopia. So first is posterior staphyloma, and posterior staphyloma is considered to be the hallmark of any pathologic myopia. And it was described by Spade as an outpouching of the wall of the eye that has a radius of curvature less than the surrounding curvature of the wall of the eye. So as we already know, the scleral shell in highly myopic eyes has increased elasticity, and they, over a period of time, tend to expand gradually and they become thin. So many theories have been postulated for this staphyloma. One is the thinning of the sclera and the scleral protrusion along zones of closure or the embryonic fissure. The second one is choroidal thinning, causing scleral thinning and leading to staphyloma. But these theories do not explain why staphyloma also happens in non-myopic eyes. So we have to look at external factors. This is some new thing which has been proposed, that the superior oblique and the inferior oblique muscles, which insert at the posterior part of the sclera during torsion, can cause some amount of outpouching of the sclera. So Curtin described the staphylomas in detail, and he classified them into 10 different patterns, 5 primary and 5 compound. And the primary staphylomas have been divided into 1 to 5 types. The first is posterior pole, then second is one involving only macular area, third is peripapillary area, fourth is fundus, which is nasal to the disc, and fifth is area below the disc. And when we see compound staphylomas, they are a mix of 2 types of primary staphylomas. There are various methods to detect. It is very easily detectable by a routine indirect ophthalmoscopy. Stereoscopic fundus photograph can be used to document. B-scan, on B-scan it is seen as a shallow outpouching compared to a coloboma, which has a very sharp outpouching. Then SD-OCT and SS-OCT. The ultra-wide field fundus photography is considered to be the gold standard to diagnose staphyloma. 3D MRIs are used in research purposes. So in this photograph, we can see only the posterior pole is seen in the fundus photograph, whereas in the wide field fundus photograph, the edges of the staphyloma are clearly and well demarcated. 3D MRI was described in some studies where they showed that after studying the staphylomas in an axil length with more than 30 mm, more than 50% of eyes have staphyloma. And they had a new type of classification, that is wide macular staphyloma or a narrow macular staphyloma. Why do we need to know about them is that the presence of a staphyloma has worse structural and functional outcomes in high myopia with more visual impairment. Chorioretinal changes are more significant in these patients with staphyloma. It is associated with high degree of myopic maculopathy, and they are also associated with myopic neovascularization. The next one is dome-shaped maculopathy. This is reverse of a staphyloma, where we have a convex protrusion of the macula detected on OCT. And this also is a result of asymmetrical scleral growth. It has been studied by many people in earlier years because the EDI OCT and the in-depth OCT was not available. The pathology was not well known. But nowadays it is said that there is increased subfoveal scleral thickness at the part of the posterior staphyloma, and there is asymmetrical scleral thinning. So 3 types of anatomical domes have been described on OCT: horizontally oriented dome, round-shaped dome, and vertically oriented dome. The horizontal oriented dome is more commonly seen. So always in case of myopia and all, when we are taking an OCT, remember to take the horizontal and vertical sections also. So even in the vertical sections, we can have new findings in regard to pathologic myopia. In a horizontal oriented dome, the vertical scan will show more protrusion. In a round-shaped dome, this is the second most type of dome, where both horizontal and vertical will show convex protrusion. Vertically oriented is the least common, where in the horizontal scan itself you can see the protrusion. So there are some complications with dome-shaped maculopathy. It is known to cause shallow subretinal fluid. It can cause incidence of CNVM, but the incidence of CNVM is said to be independent of dome. It is already associated with high myopia. This dome-shaped maculopathy also has a protective effect. It can act like a macular buckle with lower incidence of foveal retinoschisis. So SRF in the DSM has a variable range. It has been reported to be around 66 to 1.8%, but always rule out an associated CNVM if you see an SRF. And for the SRF also, there are multiple hypotheses. One is the hypothesis similar to CSR, that there is a thick choroid at the dome which is causing the fluid. The other one is similar to nanophthalmus, that there is more thickened sclera which is impairing the flow of the choroidal fluid. So various treatment modalities have been tried in the lines of CSR for this dome-shaped maculopathy also, but many times it is resistant to treatment and it keeps on recurring. The CNVM, which will be discussed again, I think later on, I will just go through it fast. It is independent of the dome-shaped maculopathy, and again, it is a type 1 CNVM, and intravitreal anti-VEGF is supposed to be more effective. Then is the intrachoroidal cavitation. This is a morphological feature which is outlined by OCT. It was first described by Freund et al. What happens here is it is characterized by a presence of hyporeflective space underneath an unaltered RP. So that underneath the RP, that hypo area which you see in the peripapillary area, that is the intrachoroidal cavitation. The overlying retina, RP and Bruch's membrane are intact here. And this happens because of expansion of the distance between the inner wall of the sclera and the posterior surface of the Bruch's membrane. On fundus examination, how can you suspect this is when the red star in the photograph, you can see the red marked areas are the intrachoroidal cavitation, well circumscribed peripapillary yellow-orange like lesions. And when you take an OCT through that, you can detect this intrachoroidal cavitation next to a myopic conus. Uncomplicated cases do not cause much visual acuity problems, but they are known to cause some visual field defects. The last of this is the myopic macular pit, where it is characterized with a high myopic patient with a deep trench-like excavation near the macular area. You can see the red arrow pointing in the fundus diagram, an oval-shaped area, that is a macular pit. And on the OCT, you can see that there is a trench-like area with entire thing is dipping down, like almost like a coloboma. But there is no RD or any traction seen at this area. So this also happens because of continuous increase in the axial length in pathologic myopia, causing choroidal ischemia, leading to retinal and choroidal atrophy. And eventually the IOP itself can cause to formation of these type of pits. Why we have to know about these pits is very rarely during a retrobulbar anesthesia, you may have scleral perforation if you pass through this. So thank you very much. And on behalf of the organizing committee, I would like to invite you for Ignite 2025, happening on January 4th and 5th at Kochi. Thank you.
Thank you, Divya, for this. I think you have finished 2 minutes ahead of time, so we can have some questions from the... Do we have anything to discuss? So what is the role of, like, if you have a fluid in dome-shaped macula, what is the role of OCT angiography? How will you use OCT angiography? Can it be used to identify CNVM, or how do you go about it?
To look for the choroidal neovascularization if it is associated, and then we can predict that it will have a better response with giving anti-VEGF rather than a plain only SRF with associated with dome-shaped maculopathy.
What are the problems, like routinely when you use OCT angiography, what are the problems that you face?
The artifacts, I think because of the deep curvature difference in the eyeball, the correct segmentation may not happen in